and welcome. Thank you again to our task force members and our consultants. I will say, I know personally what kind of time commitment this has been, and I appreciate every one of you continuing to take the time to come in. I think it's a really important task force, and I think that we've made a lot of progress. And I think you all probably would agree. We do have a quorum, so first I'll ask for roll call, and then we'll vote to approve the minutes or see if there are any corrections.
Hey everyone, thanks for coming. Just as always, when I say your name, just say here, present, whatever you feel like saying, just to let us know that you're here. So we have Dr. Susan Buttress here, Representative Richard Bennett, Senator Hobb Bryan, Senator Nicole Boyd, Miss Kay Carr.
Here.
Miss Miranda Carter.
Here.
I know that Dr. Daniel Edney could not be here today, but Chris Adcock is here, I believe.
Hey, good afternoon. And Mary Claire, he may come in to the meeting also.
Okay, perfect. Thanks, Chris.
Sure.
Representative Kevin Felsher. Dr. Tanya Fitz.
Here.
Dr.
Kevin
Heather
Felsher is
Hanna.
here.
Okay, perfect.
I'm here, and I think someone else was also stating they're here as well. Kevin Felsher.
Kevin Felsher, Representative Felsher. Miss Biz Harris, I believe is here. Dr. Carlin Hennington.
I'm here.
Senator Chris Johnson. Miss Leslie Junkin. Dr. Sophia Leggett.
Here.
Senator McCon. Representative Sam Mims is here. Dr. Denise Powell.
Here.
Representative John Reed is here. Dr. Courtney Walker, I don't think she's here today. And Mr. Keith Van Cannon.
Here.
And then also the advisors, I'll just walk through those real quick. Dr. Julie Parker. Dr. Kenya Elizabeth Wolf.
Here.
Miss Penny Manzel. Dr. Catherine Cassidy.
Here.
Dr. LaShonda Carson. I believe she's not going to be here today. Dr. Candace Carter Stevens.
Present.
Dr. William Brown. And Miss Sarah Myers.
Here.
And then Dr. Edney came in, and we have our ASL interpreters, Francis Woodward and Linda Robertson. Thank you.
Thank you again for everyone being here. Okay, next, you should have received a copy of the minutes from our meeting on September the 5th. And so give you a couple of minutes to take a look, and then if someone will entertain a motion for approval of the minutes if there are no corrections.
This is Biz Harris. I motion for an approval of the minutes.
Okay, thank you. Is there a second?
This is Denise Powell. I second.
Okay, thank you, Denise. All in favor? Any opposed? I don't think we have to vote. Motion carries. Okay. The next thing, just let me lay this out a little bit. What we thought we'd do is go over next on the agenda is the discussion of Alabama's early intervention system. We don't have a speaker coming, but Emily was able to get information from them so that they could answer the similar questions that we had asked the previous early intervention program. And so she'll go over that in a few minutes. And then after our update from Dr. Edney and the health department, we really want to talk over the early intervention task force rankings in the area of concern. And we are hoping that this will be a very interactive conversation. We really want to hear from all of you task force members and know that you guys have been spending some time trying to understand where the areas are that perhaps we may need to have some improvement. We have some opportunities and the like. And so we really want you to speak out about this. I'll just make a quick comment about the task force rankings. I know that was very, very difficult because everything on that list seemed very important. And Mary Claire and I had a conversation about how tough that was, and a couple of other people reached out. So know that it was really a good exercise in trying to make us think through what was doable. Were there a couple of major things that we could move forward on? And the answer is yes. And then what might we need to put on the back burner? So that's why that exercise was there, but you'll have plenty of time to talk about that in just a minute. So next, I'll turn it over to Emily to go over Alabama's early intervention program and the answers they gave us.
Hey everyone, thanks so much for making time to attend this meeting today. I'm going to run through the questions and answers that Alabama provided for us. Mary Claire sent out these, so if you want to walk through the document as I go along, that is perfectly fine. So first of all, we asked how Alabama's early intervention program is structured at the state and local level. Alabama provided a chart of how that looks like. They have the lead agency, which is the Alabama Department of Rehabilitation Services. They contract out with vendors, the AIDB, which is the Alabama Institute for the Deaf and Blind, EI projects, which are just local programs at the local level, and the DMH, which is their Department of Mental Health. Going on to number 2, what functions do the lead agency and the regional offices serve? They responded that as the lead agency, the ADRS is responsible for administering the funds provided under Part C and for the day-to-day monitoring and recommendations regarding the disbursement of Part C funds. The regional offices are referred to as district offices. There are 7 of those, and all of those staff members are ADRS employees. They're referred to as district early intervention coordinators, and their role is to process all referrals in their district. The goal is to place families in a local program, but if programs are at capacity, the DEIC will determine eligibility, write the IFSP, and provide services until a program is available. So you can think of this as interim service coordination. I've heard that or seen that phrase applied to other programs that work similarly. Number 3, what is the procedure for processing referrals and selecting service providers? They referred back to that second question. Number 4, how does Alabama give feedback to primary care physicians regarding patients they have referred to the program? If the child is eligible and an IFSP has been written, the service coordinator sends a Dear Physician letter with parental consent indicating the areas of delay in the planned services the family will receive. Number 5, how does the lead agency oversee monitoring and compliance for the individual programs? The ADRS and EI monitoring team conducts annual monitoring visits with all EI programs in the state. Technical assistance is provided at least annually or more as requested or needed. Moving to number 6, how many service providers are enrolled in the program and who administers their enrollment? The service providers work directly for the 43 local EI programs. At the state level, they don't yet capture the number of providers. Number 7, in reference to the criteria that local providers must meet to be enrolled in the program, Alabama provided a link to a document that lays out in detail what those requirements and qualifications are for providers. And if you access it through the document Mary Claire sent, it'll send you directly to that link. Number 8, how does the EI program extend services to the most rural areas of the state? Alabama's EI programs and providers live and work in those areas. They also offer virtual services if convenient for the family. Number 9, how does the program ensure collaboration between service coordinators and service providers? They responded that the service coordinators and service providers work for the same program. So the service coordinators don't work for the state or the full-time ones. They're interim coordinators, from my understanding, in those district offices that are run by the state. But the full-time service coordinators are part of the agencies that also offer service provision. Moving on to staffing, we asked how many staff are employed by the lead agency and what their general responsibilities are. There are 37 total, and I won't go into all the details of the descriptions, but you can check those out. Just running through briefly what some of those positions entail are the director of the Division of Early Intervention, an assistant director, some child find and data staff, staff that are over training and contracts, staff over monitoring, some district supervisors, administrative assistants, and then those district office staff that work as interim coordinators. Number 11, do all of the service providers operate as independent contractors, or are some of the providers employed by the state? They reference back to number 9, which states that service coordinators and providers work for the same independent program. Number 12, what is the average caseload for service coordinators? They responded that it is approximately 35 to 40, and in Mississippi, it's about 45 with a max of 50. Number 13, what are the program's billing and reimbursement procedures? They responded that currently Alabama reimburses EI programs using a 3-tier rate system based on hours of service provided per month. However, they're currently in the midst of a cost rate study to analyze the current financial structure of the system by comparing it with the designs of EI programs in other states. So on the phone with her, she actually reinforced that they're likely going to be changing their billing system in the coming months as they go through the results of this cost rate study. Number 14, does the program offer telehealth options for service provision? And if so, for which services? They said that yes, for all EI services, telehealth is offered, but Medicaid will only reimburse for speech, service coordination, special instruction, and vision services. Number 15, we asked about the funding that the program receives, including total state funds. For fiscal year 2014, the Alabama state appropriation was $14,702,810. Their fiscal year 2024 federal grant was $7,756,434. And still in the program funding area, number 16 is how does Alabama's legislature determine how much state funding to allocate to the program? They responded that it's based on their budget request. And then the final category, it was advice for implementing a new model. We asked how long Alabama's program has operated under its current model, and they said that it's basically remained the same since its inception with minor revisions throughout the years, which also applies to number 18, which is how long did the model take to implement? It looks like they've been working under this model for a while now. And then the final question is, do you have any advice on the strengths and weaknesses of implementing an EI program? And they suggested to utilize all available national technical assistance centers and ask questions of and follow the federal regulations. And just one final point before I turn it back over to Dr. Buttress, the Part C coordinator in Alabama, her name is Amy Blakeney, and she was very kind and gracious in answering these questions. And she said if there are any follow-up questions, to feel free to reach out to her. So if that's something you're interested in, I'm more than happy to facilitate that. Thanks.
Thank you, Emily. A couple of additional things I'll ask Emily to add before I open the floor up to questions. Emily, if you know the numbers of dollars were significantly more than what we have in early intervention, can you tell our task force the number of children that are served and the percentage in Alabama that are served, if you will?
Yeah, absolutely. So based on 2021 figures, which is the most recent federally reported numbers, Alabama was serving 3,992 children, which was 2.33% of their population of that age range.
So I'm sure everyone remembers we're serving 1.52% at present. And of course, our population is lower, but that number, that 1.52% was.
Yeah, that's 1,592 children.
Okay, so thank you for that, Emily. Thank you for your time and work on that. I'd like to open the floor up to questions. If we have any of our task force members who have questions, just unmute or raise your hand.
I have a question. This is Sarah Myers.
Go ahead, Sarah.
Emily, did the head of EI speak to what model they were looking at instead of the 3-tier rate system proponent?
She didn't go into detail about that. It was more that they were investigating lots of different options and we're then going to evaluate based on that. She said the day that I called her, or no, I think it may be today actually, because she couldn't attend today, they were going to meet about the rate study with those who were conducting it. So she really didn't give any specifics on that.
Thank you. It'd be helpful.
Yeah, we can definitely add that to the list. Sorry.
Yeah, I have a question. I know they're serving 1.2% of their population. They have much larger cities than we do. Do they have any data about how many they're serving in like the metro Birmingham, Huntsville, Mobile areas versus their rural populations? Like, is there like any data or breakdown that they provide in those areas?
That's something that was not provided and that we don't have currently, but we can ask to see if that's something that they collect at the local level.
I had a question about the telehealth point 14. Is that an Alabama Medicaid policy about speech service coordination, special instruction and vision, or is that a federal like?
From what I understand, that's an Alabama policy. Our Medicaid programs have different policies. I know that our Medicaid presently covers behavioral health for certain and psychological telehealth services. So I'm not sure about occupational therapy. That would be a little bit more difficult, obviously, than speech therapy and behavioral therapy.
Hey, this is Heather. I know I exchanged some emails with Mary Claire about this. I'm wondering, as we're thinking about the potential budget for Mississippi's EI programs, if we look at some of these other states and we see what their total budget is per the 0 to 2 population, so we understand what their capacity for serving their 0 to 2 population is, how much they have per child. If that could be helpful to kind of guide us. And then also we know our level of poverty will influence the amount that we need as well. So I think it's really interesting to see what other states what their total budgets are and then what their population is. And the percentage is, correct for that, even though another state may have a larger population than us, the percentages served take that into consideration. Thanks.
Thank you. Any other questions or thoughts? Emily will be happy to get back in touch with Alabama, and I think it'll be really interesting to find out what they've decided once they meet today, or if they have. We can come back with that at our next meeting.
Emily, I have one more question. This is Sarah Myers.
Yeah, sure.
It sounds like, and I could be misunderstanding, but it sounds like this is a lot closer of a model than what we have potentially proposed with the hub model and filling in the gaps where we need them. Am I correct in my assumption?
So part of the question is what definition we're using hub to mean. So this Alabama has these district offices, which is kind of similar to what Mississippi has in the local programs, these around the state. And then they in turn partner with agencies, provider agencies. So yes, I mean, if you're thinking of hub, meaning that only one provider agency will be overseeing entire area, then yes, Alabama is not operating in that manner because they have 43, I believe, 43 locations across the state that are covering various areas, if that answers your question.
Okay, thank you. Yeah, that does.
But does the Alabama Department of Rehabilitation Services, are they the primary intake for the funds that come into the state?
That's my understanding. Yeah, I'm pretty sure any lead agency has to be the one who initially receives and administers those funds, and then they disperse it as they see fit.
And they too are responsible for reporting back to the feds about the
That's
program.
right. That's right.
Hi, this is Kenya Wolf. I have a quick question. This is a question for clarification. So it says the goal is to place families at the local program, but if the program's at capacity, then the DEIC will determine eligibility, right? The FSP, and provide services until the program's available. Do we have an idea of what the numbers are? How many of those are getting eligibility and services from the kind of the DEIC rather than the local level?
That also wasn't specifically provided, but from my impression, that's almost a matter of last resort. So we can obtain those numbers, but I believe ideally they try not to conduct the eligibility and the IFSP services through those DEICs. Those are meant to be processing their referrals and then get them out to those local programs as soon as possible. But I can see if they would have those specific numbers for you.
Thank you.
Absolutely.
Yeah, I think that's a great question, because one issue that we know, if our service providers in the past have been at capacity, or if there's not a service provider in the area, then what we have heard from a few is that the services then are not given, and then parents are left on their own to find services. So it would be very important to know how often that gap tends to happen. If another question comes up as we're moving through, task force members or advisors, remember, we want you to go ahead and talk today. We really want some interaction. So thank you for the questions that have come up so far. And just if you have another one, just write it down so you don't forget it, and we'll come back to it. Okay, I see Dr. Edney was able to make it. We heard you might not be able to, and then you might. So I'll turn it over to you, Dr. Edney. Thank you for being here.
But there we go. Thank you, Dr. Buttress. You knew I would try to get here.
I knew it.
I spoke in Batesville early this morning and was able to get on the road in time, so I'm glad to be here. I have my senior deputy, Chris Adcock. As y'all knows, Chris has primary responsibility over the program at this point. She's going to give us an update and then be happy to answer any questions.
Great, thank you. Chris?
Hey, good afternoon, everybody. Just a quick update. We've been doing some homework on our side also, and so I'm happy to share some of that information with you. I think it's going to be helpful given the questions that you've had this afternoon. We did have a call with Maureen Greer. She's the executive director of the IDEA Infant and Toddler Coordinators Association. And it was really about her work that they were able to accomplish when she was in Indiana. Indiana was apparently one of the first states to implement a pay and chase or centralized billing model. And it took them about a year to implement that process. So I think that's worthy of noting. There are apparently about 7 states that implement this model. And some takeaways from those conversations that I want to share with y'all this afternoon. First and foremost, she expressed a lot of concern and was pretty adamant that the state has to have the initial startup funds to implement a centralized billing model. She said in Indiana, it took them, like I said, about a year to implement, and they really started in pilot areas of the state with implementation. They did include a rate study as a component of this new billing model. And one of the things that she reinforced was that there's got to be collaboration with the Division of Medicaid and with service providers to make this happen. The state was able to negotiate with Medicaid that they implement batch claiming, the use of modifiers, and probably one thing that will be really exciting to Dr. Buttress is that they were able to adopt the IFSP as the authorizing document for services. And so that was game changer in their state when they implemented this new model. One of the things that they saw was with the centralized billing model or the pay and chase model, they saw that their numbers of service providers really increased because the administrative burden decreased and the turnaround on payments was much quicker when they moved to this new model. A couple of things that she did point out that are probably worthy of definitely more study. In Indiana, and I think there are about 4 more states, Texas being one of them, they also use some TANF funding to fund their early intervention programs in those states. And so that was one thing that she did bring up as an area that we would probably need to look at. I was very encouraged after the conversation with her about implementing this model and about the impact that it may have on families and increasing our service provider pool. So that was very encouraging for us. We're also working through language for an interagency agreement with MSU for the pilot project that was put in motion during the legislative session. We reached out to our federal partners at OSEP just to get their take on things, make sure that they knew the direction that we were heading with this model. And one of the concerns that they brought up was that we need to be cautious about an unintended consequence of losing service providers in the proposed area. And so what that really means is if we are moving into this pilot project, then any new referrals coming into the program in that East Central area would be referred to Mississippi State for evaluation and service provision. So OSEP really encouraged us to think through this interagency agreement, to think through that process so that we don't have the unintended consequence of losing service providers. And they are on board, they're encouraging, and they are willing to help us work through the language in that agreement. So some good takeaways and some progress being made just in terms of exploration of new models. And Dr. Buttress, I'm happy to answer any questions about that.
Thank you so much. This is a lot of good information. I have a question.
Sure.
Did Indiana have a good idea of the initial startup cost of that model? Also, do you know the numbers that Indiana serve? Emily, you may have that. Huh?
Yeah, just a second.
I don't have that currently because Maureen is not the director there currently. She was speaking on her experience when they implemented initially, which was like early 2000s. So I don't have those current numbers. And then she was going to send some more financial information that I can share with the group also when I receive it.
Yeah, they're serving 11,346 children, which is 4.73% of the population. However, they are in that needs intervention status on the federal regulations. So they're serving a lot of children, but perhaps there are some areas for improvement in that state as well.
Thank you. Any questions? Okay. Well, thank you for that update, and we'll be looking forward again to gathering more information from that area. Yeah, the needs intervention status, it'd be interesting to see where that's coming from. Okay, let's see, our next. Now, this is the big one, and again, we left plenty of time for this, and I think we're a little ahead of schedule anyway. Yeah, we're really good. So Emily, not Emily, Mary Claire, getting my children mixed up, sorry. Sorry, Mary Claire has a good presentation to sort of lay it all out for us and let us take a look at what we said. And there was a lot of agreement, actually, believe it or not, in that very difficult task. And so we'll let her present, and then in the end, I expect that there'll be some thoughts and questions. So take it away, Mary Claire.
Thanks so much, Dr. Buttress.
Mary Claire, this is Kay Carr. I'm sorry, can you pin the interpreter so I can see the document and the interpreter at the same time? Please.
Okay, try side by side mode on your screen and see if that helps.
It's not letting me.
Okay.
You can't. I'm not sure if we're going to be able to do that. So, Kay, are you not able to see the interpreter on the bottom of your screen? If right now I can see the slides and the interpreter on the sidebar. And if you look at the top of your screen, you can go to how you view the group.
It's not allowing me to do that, Dr. Buttress, but I can just follow along with the interpreter. That's fine.
Okay, I'm sorry, Kay. Thank you.
It's okay.
I'm sorry about that, Kay. Okay, so I think most people are familiar with me at this point, but I'm Mary Claire Ringer. I'm peer staff, and I've been providing administrative support to the task force. I'm the one that sends you all the emails on a daily basis, so sorry about that. And then we also have Emily Cloyce, who just presented for us, but she is also peer staff, and she's been providing the research assistance, and she's great with knowing what's happening in other states as far as early intervention. So we really appreciate that. And then today we really just wanted to talk to you all about the early intervention task force rankings that you all completed over the last few weeks. And so the purpose of my presentation today is just to explain the importance of the ranking exercise, discuss our analysis of the rankings, and then provide suggestions for moving forward. And then also, as Dr. Buttress has said, really our goal today is to have an open discussion of task force members and advisors, just to talk about moving forward and kind of where you see things going with the task force. So first, I just want to say thank you so much for the participation and input for the early intervention rankings. We really appreciate it. And as Dr. Buttress says, it was not an easy task. There were many areas where you didn't want to rank it 25 because you thought it was just as important. So we do appreciate everyone taking the time to do that. We were happy with the response rate. We had 20 of 29 members and advisors of the task force that submitted rankings. So that's a really good number for someone who sends out a lot of surveys. We were happy with that response. So thanks again for that. And then, so the purpose of the exercise was to determine what the task force considers the most important areas to address moving forward. And then hopefully the responses will help us provide more direction going forward, and really just relying on the experts to decide next steps and making the best recommendations to the legislature and to the Department of Health. So what we did is throughout all of these task force meetings and through the public comments that we received, there were so many areas, even more than the 25 that we put in the document that we sent out to all of you, that people were interested in addressing. So what we did is we tried to group them together the best that we could, and we kind of shared that with Dr. Buttress, and she helped us kind of get it narrowed down to the 25 areas that you all saw. So we sent that list of areas to all of you, and each area was ranked 1, meaning most important, or to 25, meaning least important. And again, even if it was ranked number 25, it doesn't mean that it's not important. It just meant it might not be a priority at this time. And so what we did is we compiled everyone's results into a summary spreadsheet and arranged it in order of most important to least important. And I sent you all that yesterday, as well as I believe I sent it out this morning too. So you should have that. And we ranked each area by average score. So in the summary that you have, it's 1 through 25, and that is ranked by the average score. And we also included the number of times areas appeared in the top 5, the top 10, the top 15, and then also the bottom 5. And the reason why we did that is that it was interesting to us that sometimes one person's number 1 was actually someone else's number 25. So we thought it was important to show the different counts of where each area landed. And here, I'm not gonna read each of these, but here's the top 5 and then also the bottom 5. So number 1 was improving the referral process. And then the bottom 5 was identifying incentives to recognize and award staff and service providers for performance. And again, while that is important, at this time, it may not be a high priority over other things such as improving the referral process. So next is just suggestions that we have that for you all to consider for moving forward. Now the first one, I really hope that we can make this happen, but a draft of the report should be completed around November 1st, 2023. So the task force is required to submit a report to the legislature and the Department of Health with recommendations by December 1st, 2023. So I really feel like we've got to get a draft done by November 1st in order for the task force to meet probably multiple times in November to discuss and finalize the draft report. So we really are pushing for that November 1st date. And then many of the areas in the rankings can be grouped under broader categories such as program structure, funding, training and outreach, and there are other ones as well. Those were just examples. And then within each of these categories, we can list subcomponents that need to be addressed in order of the task force's priorities. So there are many items on the list that can be implemented now by the Department of Health prior to changing the service delivery model. And a lot of these are internal changes and policy changes. And the Department of Health, Dr. Edney and Chris have already said that they're working towards some of these items already. So that's really great, even prior to the task force making a recommendation. But some of these things that can be implemented are improving the referral process. Again, that ranks #1. And I know that's a high priority for Chris and Dr. Edney. And then I'm having trouble reading the screen, but recruiting well-trained professionals, I think, is one. Improving coordination and communication with referring physicians, service providers, service coordinators, and parents. Increasing outreach, education, and community awareness. Expanding the program's eligibility criteria. Selecting a standardization process for eligibility determination, and then continuing what they're already doing, their efforts to increase the provider rates. So again, these are things that the task force can recommend and help the Department of Health kind of determine how to go about each of these areas. But they're already doing a lot of this. They're already trying to do a lot of this as well. And then the next thing, there are other items on the list that are more complex and will require additional thought, time, and research. And I know all of these things are very important to the task force, but changing the service delivery model, researching and implementing a pay and chase model for different billing system. You heard Chris speak earlier. She talked about that it needs more study before moving forward. And then increasing funding to allow for expansion and improvement of services. So we really don't think that at this time, the task force will be ready to recommend a specific service delivery model by December 1st, 2023. But because changing the service delivery model is so important, we've heard it over and over at these task force meetings. We believe that it will require more research to really determine which model will work best in Mississippi. We've had some members contact us and express interest in hearing from more than 2 or 3 states and reviewing different types of models, for example, a hybrid or hub model. And then Dr. Buttress can correct me if I'm wrong on this, but I think one goal, and Dr. Edney too, but one goal I think they have is to decentralize the program. Right now, where a lot of it is done at the Department of Health, but I think they want to move it down more locally. And so that's one of the goals of the task force. And this changing the service delivery model will require the Department of Health to develop a plan to determine, among many things, cost, billing options, service areas, and staffing. So they just need more time to be able to do that. So in the report, what we're kind of suggesting that the task force could consider doing is they could provide a list of the different model options that are service model options that are available so that the legislature kind of knows what is even out there, things that they may not have ever considered. And then the task force could also recommend that the legislature consider passing a bill that would require health to develop a plan for implementing a new model and billing system. And then the bill would need to just set specific responsibilities and priorities for health over the next year. And then to extend the early intervention task force in some capacity to assist health in planning for a new model and billing system, such as the pay and chase model. And again, kind of my idea of extending the task force, it would be more of like an advisory role. And I would see it not meeting as much as you're meeting now, once or twice a month. It would be more kind of quarterly, every so often, just to help the Department of Health as they move forward with improving early intervention services. And then again, these are only suggestions for all of you to consider. The task force has the ultimate responsibility to decide how to proceed. However, whichever path or decision is made by the task force, it must take into account the time and adequate resources needed to implement a new service delivery model and billing system. And again, peer staff is here available to help with the research assistance. So now I'm happy to try to answer any questions at this time, but what we really are hoping for is just to have an open discussion for task force members and advisors, just on potential next steps, concerns, considerations, and recommendations. And thanks for listening to me today.
Mary Claire, this is Heather, and if it's okay, I'll go ahead and make a comment. I'm really pleased to see how you're using the information from the rankings. I think if I would have had sort of this type of conceptualization prior to being asked to make the rankings, it would have made the process a little easier. And I'm just wondering, in terms of next steps and so forth, does it, it's been mentioned several times, national TA, and I'm just wondering if it makes sense for Mississippi to have a dialogue with some national TA, trying to understand the models that are working well in other states, and let that be met with the Mississippi knowledge to try to determine if there are modifications of other models and so forth. But I love the fact that we are not, I was getting a little nervous. I'm really glad that we're not trying to rush to make a recommendation on an overall model. I think you guys are doing a great job in thinking about this in ways that make sense. But I'm just wondering about the TA, the national TA dialogue.
That actually would obviously need funding, and this task force doesn't have any funding. And so that would be something, I think our group as a whole, I'd love to hear from other task force members. What do you think about putting that down as a request in the report? We can certainly do that. I think one thing that we've discovered is there are lots of different models. It doesn't sound like there's any perfect model. What we've been trying to look at is, in general, what seems to make more sense, and bringing things down more to the local level so that care coordination and the like is there and in the community sounds like a good idea. The other thing that I think we all know is that more money needs to go into the early intervention program to really have a robust system. I think we all agree who are in this task force that we need to serve more children. But to be able to do that, it is very clear that more money needs to go in. So with that said, I'd like to hear what everybody thinks about Dr. Hannah's comment on bringing in national TA. I think that would have to require us making that request to the legislature.
And we can also, we had a comment on the, from Dr. Hannah about maybe there's federal resources that are free. And we're not sure, but we can definitely, that's something that we can look into and maybe talk to the federal partners about that.
Right, because that comment was made from Alabama to use the national TA that's available.
And that's what we do. And I mean, it's what Chris reported to you. So we reached out to our federal partners for technical assistance, and they're great about giving it. And I'm going to tell you what I have learned so far is when you're given technical assistance, you better take it. And if you don't, it's at your own peril. So you heard today the technical assistance that we received. To funding, Dr. Buttress, let's be very clear. Alabama is currently funding their program $11 million per year more than Mississippi. And last year, we were blessed to have a bump of $2 million that all went out to providers. Before that, we were operating on $1 million.
Right.
And you wonder why we're here?
Right.
So we need to be blunt. I mean, we're talking about big dollars. And, and I know for some colleges and universities, 10 million is, that's front pocket money, but at the health departments, that's straight state treasury money. That's a lot of money.
That's a lot of money.
So you've heard us say we're all in on pay and chase, but we don't, it's all dependent on funding.
Right.
And I would say, asking for a statute to require us to look at other billing models, which we're already doing, and if we can't do pay and chase, then what? So as we write this, please be thoughtful and careful, because statutes have consequences, and whatever it says is what we have to do. And I'm not sure what other billing models we could change. Now, we can be more efficient with even how we do now, which we're already working on. I hope we can get to pay and chase. That's dependent on us getting the appropriation that we would need. We still don't know what that figure is, and we're trying to get to it.
Right. I think that for our providers, I keep thinking about our speech and OT and other service providers out in the community, trying to give services and bill at the same time. And the amount of organization and time, and most of us who grew up in medicine or allied health professionals did not have big business courses. So to me, the pay and chase model sounds like a relief. I'd like to hear from some of you who are on our task force who have engaged in providing services. Does that seem like what we need to go after?
This is Keith Buncannon. Pay and chase seems like a dream, but I feel like there's going to be some obstacles, because billing, we have to have the prior authorizations. I think one big step toward going in that direction would be that we need some modifiers that would eliminate the prior authorizations. And that would take getting Medicaid on board to do that. Because if the child already meets the percentage of delay, then why should Medicaid have to pay an outside agency to work a prior authorization when the child is already obviously in need of services? So I think if we could get Medicaid on board, that would help the progress toward pay and chase, but then there would have to be a substantial bank there to pay the providers. But that would help with prior authorizations and payment sources.
This is Dr. Fitz. I do have a question for Ms. Adcock. When they were talking about in Indiana that they moved for the ISFP being the authorizing documentation for the PAs. Like how did they go about doing that? Do they have MCOs like we have MCOs, like their managed care organizations, their Medicaid managed care organizations? There seems like, because we're getting complaints on the state AAP level about one particular managed care organization just point blank denying all of our kids on Medicaid their PT, OT, and speech therapy that that is just like recent, right? So do you know how they went about doing that, and how they got all the managed care organizations to agree to that?
Yeah, so a little bit of that history I do know. In Indiana, they are an umbrella agency. So the same commissioner who's responsible for what is known as their health department in Indiana is also responsible for their Medicaid program. So that's going to encourage collaboration right there. But I think that is where she spoke to the fact that the collaboration with Medicaid is key. So it would take some heavy lifting with Medicaid to have the IFSP recognized as that document that is prescriptive, so to speak. And Keith is right, the use of modifiers would need to be included so that we can see in the system where the services that the children are receiving. So I don't think anybody's going into this with blinders on, thinking there's not a lot of heavy lifting that would have to be done.
Yeah, I mean, for our wellness visits, we do already an EP modifier for EPSDT. Is it a similar type modifier that the service providers would have to add?
So it would be something similar, I would imagine. In a former life, when I worked in mental health and the community mental health center system, there were modifiers that those service providers used so that you could isolate those claims in the system. I would think it would be similar. I don't want to speak for Medicaid though.
This is Biz Harris. I have to say that this feels really, I was thinking about all these things because I was on the TA that Mary Claire sent out about infant and toddler mental health, maybe last week or the week before. And they actually had a chart that showed the way that showed how modifiers could be combined or related to each other. So I'll see if I can get a recording of that, because I think it was really relevant to this conversation to help Medicaid understand, to help bring Medicaid along in this conversation, because I feel like that is critical, especially if we're talking about, funding and getting these services covered for our children. I also have something that feels irrelevant, but I also want to make sure that it's on the record. Apparently Chicago is thinking, and Illinois is thinking a lot about children that are automatically eligible for services because of, for instance, a NICU stay. Like if you were in the NICU, you're automatically, you don't have to go through all of the intake processes. You just automatically begin, being in the early intervention system. And so I think when I looked at the 6 priorities, or the priorities that wouldn't necessarily take legislative action, but could be discussed by the health department, that was something that I would love for us to think about. How do we make sure that we're removing barriers to catching children? And maybe we're already doing that, but that's something that we haven't really talked a lot about in this.
Well, I think that's a great idea. I mean, presumptive eligibility makes sense in a lot of areas. It definitely makes sense here.
Hi, this is Denise, pediatrician on the Gulf Coast. Piggybacking off of that, so I trained in California, and it's a similar model where if you have a NICU stay, if you're high risk, you automatically just get into the system that way, and it worked really well. So agreed with that. And then I just wanted to touch on number 8 in the suggestions moving forward, recruiting well-trained professionals. If one of the things we're talking about is funding and looking into federal funding and that kind of thing, we could think about loan repayment for speech therapists, physical therapists, occupational therapists who are early in their careers, who maybe that would be a really good incentive for them. So I think that would just be one way to recruit and maintain people. So just something to think about, especially if we're thinking about unique ways of digging into funding state and federal wise.
Many good questions and comments.
Dr. Buttress,
Yes.
in terms of continuation of the task force, which I'm fully supportive of, I do want to remind everybody that we do have other statutorily required advisory groups, and who has priority, who's senior. I mean, we need to be respectful of other volunteers working on other advisory councils. What's different now compared to before I came on is the communication problem from the advisory councils to the state health officer has been a big problem. It's no longer a problem, believe me. The chairs of each of our advisory councils now direct report to me, and the recommendations and reports come to me. And then I engage the staff to facilitate the recommendations from the councils. That was not happening in the past. And it's more than one council. So, that is fixed. So as this task force continues, we need to decide how it's going to interact or make sure we're not stepping on other toes.
I think your point's an excellent one, and it might be good for us to talk about right now. What are those other councils? We have CCAC, We have the State Interagency Coordinating Council. We have, what other ones would you believe, Dr. Edney or others, need to be included in the group that makes sure we interface? I know we've been certainly trying, because I sit on both CCAC and this, to coordinate with those. I've tried to attend the SICC meetings as much as I can, but I think we need to, that is something we really need to talk about, because we all don't need to be doing the same job separately. We need to do it all together and coordinate and make sure whatever we recommend to the health department or to the legislators, that we're doing it in a unified fashion. Otherwise, we're confusing to our legislators who are trying to do good, and our health department who is trying to do good. So those were the two you were thinking about. Are there any others that anybody would like to mention? Dr. Fitz, I'll ask you. I know that the State Academy of Pediatrics chapter has regular meetings with Medicaid, for example. And I know that some of the concerns that you were talking about have been brought to Medicaid. Do you believe that perhaps some people from the AAP should be included in some of these discussions, the executive committee or whatever? I'm just throwing out there. I know there are many other professional organizations, but our pediatricians and family practitioners who see children have really been struggling with this issue.
Yeah, I would say that an inclusion of a pediatrician in whatever goes forward is definitely welcome. And as we start making some changes, I would think that we would need also input from the speech language pathologists and the physical therapists. I know we make the referrals, but they're the ones who have to implement everything. And you know, my physical therapist, occupational therapist friends who own businesses are very frustrated with Medicaid. And if we could do something similar to what we've done for the pharmacy benefits and have more of a standardized PA process for PT, OT, and speech and behavioral interventions, that would be amazing. That's probably asking way too much. And I'm glad that we only have 3 MCOs to work with and not 8, like some states. But trying to get them all on the same page is almost like herding cats. So without being told to work on the same page.
Dr. Brochus, I've got Chris in my ear, right? And she made a good recommendation, I think, in inviting the Division of Medicaid to join us. And Chris and Tracy Buchanan work really closely together between the health department and the division. They have a good relationship. I'm sure Mr. Snyder would appoint someone to come and work with us.
That's exactly what Mary Claire and I were whispering to each other. Clearly, who we need at the table is Medicaid, because some of the barriers that our families are coming up against and our providers is the process. And the health department can't fix the process. And I know PAs were one of the big complaints that we heard from providers at the beginning of all this. So, I guess my question is, do we try to bring someone in? Ted, I'm going to ask, I'm looking at you. Can we add someone to our task force now for the next couple of months as we're working on our proposals?
Adding somebody as a voting member, I'm afraid would be impossible, but we could certainly invite somebody here to be an advisor. And when we propose legislation reauthorizing the task force, we could certainly add it.
Okay. Could y'all hear that? Remote listeners? So could we entertain perhaps a motion to invite someone from Medicaid, someone with decision-making capacity to be on this task force with us?
So moved.
Who is that?
Biz.
Oh, Biz. Thank you, Biz. Is there a second?
I second. This is Denise.
Okay, Dr. Edney. Oh, and okay, let's have a vote. All in favor of inviting Medicaid?
I
I see some nods. Are there any opposed? Oh, okay. I am.
If
Okay.
if I can speak up, this is Carlin.
Yeah.
I recall the state ICC having a discussion amongst themselves. And there are some other folks. Keith is here. Leslie's here. We had a discussion about the need to have some of the entities that are on the state ICC representatives of various agencies at the table. And so I'm wondering, based upon that recommendation that the state ICC had, if there are other representatives that don't need to also be invited. Certainly Medicaid is critical. I think the state ICC has found that. I see Keith nodding his head yes, but I'm not sure which of the other agencies might be important.
Thank you, Dr. Hennington. Any thoughts on that?
Dr. Butchers, it may work if the other groups, advisory groups would be so inclined that we could just meet jointly in their official capacities. And Ted, I would think they could do that. You know, it would have to be at their discretion. But I think that would be very effective. And we can all be working together instead of having 3 different meetings.
I think that is a great idea.
I would echo that, Keith. I know that the state ICC has its next official meeting in October. We moved it from about mid-October toward the end of October. We can certainly have a discussion prior to that point. I do not, it's a public meeting. I do not that the state ICC have difficulty. Anyone having trouble with my? I was having trouble earlier. Had to log out, back in.
I guess one concern Mary Claire and I were discussing is now we do have a report that's due. We want to fulfill our legislative obligations. I think in the future, perhaps meeting together as we move forward to collaborate better than has happened in the past is a great idea. But I want to make sure that we plan to meet at our next meeting, that we plan to get this draft done, that we plan to get the draft out to the present task force right now and complete our job at hand as we're making recommendations. So what I'm thinking is that could be included as a future recommendation.
I think that's a great idea.
And you could also invite any of them to come and sit in the audience of the meetings. I mean, we're
Absolutely.
and our next meeting is October 16th. So I think I've sent that out to everyone.
Dr. Buttress, this is Sarah Myers. I just wanted to go back to something Dr. Powell shared that I thought was very insightful in discussing kind of those big three providers that we're constantly trying to recruit and produce more of, PT, speech. And just echo that if we can get more of those folks at the table, I think that would help us tremendously moving forward. Because most of my discussions have, revolved around, I think, one of the priorities, at least, that the task force looked at was providing and recruiting more trained professionals. And I want to make sure that the task force recognizes that these folks are very interested in the training and would like the support. And I think they're ready to come to the table, as we move forward and kind of make those recommendations. If we can pull in, maybe partner with more of those university programs producing those folks. I'm not sure exactly, but I know that they're out there and they're very interested in working in EI.
Good point. Thank you, Dr. Myers.
Dr. Buttress, this is Katie Cassidy. I'm an OT early intervention provider, but I'm new, almost completing my first year. But I wanted to comment about the Medicaid question. This may kind of go along with discussions with the way that we bill Medicaid, because I was told at one of the first SICC meetings we went to that other states have a bundle that they bill for early intervention services. And somebody here may know more about that, how that works, because the way I ran into it was best practice in OT in early intervention is parent coaching. And so if I'm reimbursed by, MSDH, then I can provide that best practice and get paid for that. But if I'm billing Medicaid, the way I was trained is that I have to be providing direct therapy to bill those codes. So I'm not always able to do parent coaching like I can. And like I said, I'm new, so I don't know, but that was what I was told, is that other states have figured this out to have that bundle of codes for early intervention.
Chris, do you have a comment on that?
Probably not a very good one, Dr. Buttress, other than acknowledging that it's a concern.
Dr. Edney?
Yeah, it's a legitimate concern. The division has been moving towards unbundling things, at least in our world, and it makes it significantly more difficult. The pay and chase will eliminate that problem if we can get there. But if we're not able to get there, that just made me think things like that could be alternative billing. I just need a fallback.
Right.
So that I'm not out of compliance with statute. And then also, as you're writing statute and we're inviting another state agency to the table, you're giving directives to us that we're already agreeing to.
Right.
You very likely will need to get some directives to another state agency that I have no control over.
Right. Exactly. And I think, again, we need Medicaid at the table to help talk through this, because I know Drew Snyder, and I know that he's not trying to make things difficult for anybody. And so I think what we need to do is make sure that everything's on the table. Now, back to the comment about best practice and yes, parent guidance and direction. I wonder if it's just a billing question that could be approved. I know that my office bills for parent-child interaction training. And the psychologist or the behavioral therapist wears a headphone and they direct the parent to do what they're supposed to do with the child. So that's sort of parent-directed therapy, but it's a billable service. And I'm not sure if you are coaching the parent to do what they need to do every single day, because an OT can't give therapy every single day, or a speech therapist, why that is not billable. So that is direct services. And so I think that's a discussion that we need to have with our insurance providers, because that has been interpreted in other arenas as direct services.
Dr. Buttress, I think, again, that speaks to that provider training, because I think you've got a lot of folks out there who are interested in EI, but they just have no maybe understanding of how it should look like, or how we can bill for it and work within the system collaboratively. So I think, again, that's such an important piece, is getting those folks that do this work involved in the discussion to understand how to do this effectively.
Agree.
Okay, this is Dr. Fitz again. I have another question. Do we have any data on the children that are served that are also on commercial insurance versus Medicaid? Do we need to have those payers at the table too?
We have, go ahead.
We've talked with health, and that's something that is unobtainable right now. Dr. Edney, yeah.
Right, Emily, I can tell you that it's very easy for private payers, including the predominant one in Mississippi, to opt out of covering any of these services. We oftentimes wind up being payer of last resort for private insured children. That means it's government resources paying for those with private insurance.
And that's been my experience too, as a developmental behavioral pediatrician. Many times we're relieved if they have Medicaid versus private insurance. Right. And that has long been a problem, and something that many believe should be addressed.
Well,
not sure.
I'm just bringing it up officially. Like, I know that that's a long-standing problem.
I'm not sure how we could obtain any kind of information on that, because there's not been information sharing. So don't know what to do.
That's right. And they don't have a legal requirement to share. That's proprietary information, so they don't have to share anything unless they want to.
On the referral form, there is a area for insurance information. Is that been collected by MSDH?
Did you hear that? I'm sorry, Dr. Edney, I'll repeat that question. On the referral form, there is an area for insurance information on the intake forms that go to early intervention referrals. Is there a way that perhaps we could pull that information from you guys?
I would think so. And because we know it on the front end and we know it on the back end, because we know what the denials are. Right. And we should have that information. I don't know how easy it will be to get at it, but Chris and I will look to see what we can get.
That actually would be very good information.
Sure,
because
absolutely.
That adds more burden to our state Medicaid system. Well, really not Medicaid. It adds more burden to the health department to have to pay for the services as payer of last resort.
That's right.
Yes.
And the more we're not able to collect from private insurance, then the more we're dipping into our bank, which would be state resources. And that also brings up the point, Dr. Buttress, the only way that Pay and Chase will work is everyone providing services will have to be a Medicaid provider. They'll have to be. Otherwise, this won't work. And we have to have the opportunity to build an outside payer source, or we won't have the funding to cover it.
Right,
And also, there's no reason not to draw down federal resources, rather than, and preserve our precious state resources.
Absolutely. And there's no reason that all the providers could not be Medicaid providers. Have any task force members have any comments about why all of our early intervention providers could not become Medicaid providers?
Dr. Buttress, this is Kay Carr. Can special instruction be billed under Medicaid?
Right now, I don't believe so. And so that's a good question. And Kay, and that is something that we need to check into. We are not 100% sure, but I believe special instructors cannot bill. Chris, do you know that?
That's correct. I think some states have modified their definitions and qualifications a little bit and may be getting it approved under developmental therapy of some type.
Chairman Reed is the expert, but I would think that we would be able to do things legislatively through state plan amendment with, changing some of the requirements of what Medicaid covers. And so there's opportunity within the legislative branch for that to happen.
I'll try to attempt my best to answer Dr. Buttress's question just from my experience and perspective. In that the administrative burden of working with Medicaid has been a little too great, I think, in our current system. And I think that again goes back to the way the system is structured, where mostly we're looking at independent contractors doing this work. So just from my perspective, that may be, again, why folks were hesitant. And again, she talked about parent coaching and that model being best practice and those kind of peer-to-peer learning environments and some of the restrictions that Medicaid puts on that. But again, if we bring Medicaid to the table and talk these things through, I think they'd be willing to help us expand.
Thank you again. So we know one recommendation right now, bring Medicaid to the table. Okay. Are there any other thoughts? This has been great feedback. I think Mary Claire and Emily have been writing furiously, getting everything down. So we still have some time. So if there are any other comments or thoughts or questions, please jump in.
Dr. Buttress, this is Kay Carr. So we keep talking about the hub model, and can you give me a brief description of the proposed hub model? I guess I've missed that, and I don't know that I'm clear on what's being presented.
Sure, Kay, I'll go ahead and tell you. The original thought was that there would be a centralized place like the health department that would be the hub, and then there would be satellites. I believe it's somewhat similar to what Alabama has, that there would be different areas of service that would have their own pod of service providers. Okay. And so we originally had talked about them all being linked to universities. But in Mississippi, we have some areas of the state that do not have a university hub potential even within a 40 or 45 or 60-mile radius. So we then started wondering if some sort of hybrid type model would work, so that if a university system had a hub, if it was a private entity, that had a satellite, or a private entity had a satellite office with all the service providers and case coordinators and all, they would be able to operate in that area or in conjunction with the university. I think there's been a lot of discussion about that. So it's really not that different than what was originally happening back several years ago when there were 9 different districts and there were service coordinators in those different areas. But again, Kay, we're not at this point ready to make a hard recommendation about exactly what that would look like because we feel like we need to do more research. That is what Ted, Emily, Mary Claire, and I believe. And we want to make sure that the task force agrees because it's not just our job, it's the task force job to come up with recommendations.
Dr. Butcher's a really key point to the almost proposed model is really what Tennessee is doing, those access points. And what we're willing to do, and I think it's a really good idea, is as we establish those access points around the state, they're autonomous in their area. We're delegating our authority down to them, and we are, we're holding them accountable. But then those access points or pods or whatever we're going to call them, they're the ones that'll be interacting with the providers. They'll be recruiting the providers. They'll be interacting providers in terms of service providers, but also medical providers. And I love that idea of the community-based model, and then our role being lead agency to run the program and keep compliance, keep the feds happy, manage the big money, and be the bank. Then hold our access points accountable, and then access points hold the providers accountable. That makes such good sense to me. And however we morph that to work to everybody's agreement, I think we can get there.
This is Biz Harris. I also agree that a community level approach, a more localized approach, really empowers local communities to really pull together for their children. I think that it also, this is a question that I have, and I know that we haven't really prioritized it, or we've been focusing so much on access. I haven't seen any, I guess, like data on developmental milestones by the 1,000 and how many? 1,592 children that we're serving. I would love to know if we have any, longitudinal data about how their growth is doing after getting services. And the reason I say that is because whatever we propose later in this hub model approach, I would love that to be a part, because I would really love to know, because I think in terms of holding people accountable, it really helps us have data. And I think that's one thing that when I think about little people in our state, I really want to make sure that we're, I just feel like the data is everywhere and nowhere at the same time.
Right, I think that's a good point. And if you have a program, you want to make sure that it's a program that is showing improvement and progress. And so one piece that I've been interested in looking at is the number of children who are in Part C services, early intervention services, versus the number of children in Part B. And I know they're somewhat comparing apples and oranges because some things don't become apparent until a child is older. But at the same time, if we could look at just those first 2 years in school at a 4 and 5-year-old, our pre-K collaboratives are getting larger. If you have a child who enters into a pre-K collaborative and they are struggling with the social, emotional, and the developmental issues, could they have been better had they been in early intervention program? So I agree, we need some way to be able to judge how well the program's doing, because in the real world, early intervention for many of the milder developmental disorders, by the time a child enters school, if they get appropriate intervention, they should be ready to learn and not struggle. And so I know, we've made progress with our third grade reading and all of that. We've made great strides there. I think we could make even more if we had the kind of robust system and the support. So I don't know, anybody else want to make comments about what Biz's point is?
And Dr. Butcher's another key point to what our responsibility, as I would see it, would be to Sarah's point, having heartburn about dealing with Medicaid is it would be our responsibility to do all the billing. We just have to get you enrolled, and that's for us to provide technical assistance. And we're experts in that area, so we can work with everybody. And so things that might be giving people heartburn in terms of their responsibility in the community, we still are there to support them.
Thank you.
Do we know right now, maybe something Ms. Harris said sparked this question in my head, but how well maybe our private providers, our independent, providers are communicating with Part B if they're seeing those preschool age children? I'm just curious if there's a better communication system happening that way. Probably not, but I know that was something that was a priority that we said the Department of Health could go ahead and obviously try to look for better strategies to implement communication between, the PCP and the providers and the state systems. I just know locally that's an issue for us. So it may be for other areas of the state. Just curious.
Yeah, we certainly heard many complaints from providers saying they didn't know what was going on with the children they referred in, the medical providers. Once they referred children in, they weren't getting that feedback loop closed to know whether children qualified or not, whether they got into services or not. So that was one. The other area that you mentioned, Sarah, is the movement from Part C services to Part B services into the school. We know there's a breakdown there. Sometimes that supposed to be seamless, and if children continue to need services, then that transition should start 6 months before they age out of the early intervention system. Some of that is done well, some of it is not done so well. And so that's another area that could probably use some looking at and in a way to make sure that what's supposed to happen is followed. And again, one of the issues is that the standards can be there, but having follow-up and making sure that the providers are following best practices. And so again, to be able to make sure that that is happening, we have to have well-trained individuals, we have to have standards, and we have to have people checking on those standards and making sure that what is supposed to be happening is happening. And so training may be part of it, but I also think having the capacity to oversight is probably another issue. And I know we keep coming back to funding, and I will say this, and Dr. Edney, please don't take insult to this, but I will say we've said this very clearly, that without making some of the changes that we need to be implemented, just putting more money into the system the way it was before would not be effective. So I think that is something that I think you're nodding, we all agree on. We know that some changes needed to be made
And
are being made.
Have been made and are continuing to be made. The other huge advantage of this new model, those hubs, those spokes, or whatever they're going to be, won't be under state personnel board. They'll be contracted with us. So that's a significant freedom in terms of recruiting talent and higher level professionals that we just cannot do. I can't pay people the level to bring them into the program but our community partners could, because they would be free from those burdens. So you should be able to get the professionals that you're talking about.
Right.
Today, I can't do that.
Susan, can I make a crazy proposition?
Sure.
Okay. I've been concerned, oh, we don't need to look at too many states, but I'm going to be honest. I'm just going to be completely transparent and tell you that if I am presented with more information from other states, I am not sure that I can really parse out what pieces of that are evidence-based, like what's producing the result, what's the piece that we are interested in. It seems to me like we have a lot of the best minds in Mississippi coalescing around a proposed model that has just been expressed by you and Dr. Edney, and that we have the Department of Health at the table with us working on this. And if we can get Medicaid at the table with us working on this, that we potentially put that model forth as a straw man and work with national TA, folks who, basically we are going back to the drawing board. How do we build this up with best practices in every area? There's a group, the Early Childhood Technical Assistance Center, that I know has worked with early intervention here before. Utilize them, utilize the other federal TA that we have access to, and just really try to build from the ground up a comprehensive model using this as a straw man.
I don't think that's crazy at all. Yeah, I think it's a great idea. Any other comments?
Do we know, Dr. Buttress, and this may be again, do we know what the hesitation would be to not move in these directions? Is it kind of what Miss Adcock spoke to earlier, where we didn't want to lose any of our service providers who are already at the table? And I think, I see some head nodding. I think that needs to be echoed clearly, maybe again at these joint meetings or in a statement or something to our other councils, is that none of us want to do this alone. And we know how big it is. So we want more people at the table. And maybe if that comes with this recommendation, I agree. I think we're all saying the same thing, that we think the system needs to change, and we all think there's lots of different pieces we could pull to make that happen that work for our state. But we want to make sure that we bring alongside those people that are in the trenches right now.
Dr. Bustos, this is Kay. Again, another person that needs to be at the table is OSEP. Just to make sure as we're building and implementing, or even discussing implementing, that to make sure that OSEP is there to help guide. That was one of the recommendations that Alabama had made, was not only the technical assistant piece, but also following federal regs. So as we're adding people to the table, I propose we include them.
Right. Agree. Thank you, Kay. Right. I think to Sarah's point, we want to make sure we don't have any unintended consequences. And that's something that we have to just make sure as we're stepping through this. That's why it's so important to get feedback from all of you and from all of our advisors, that we really are laying it all out. And I think that was one of the reasons that we had some concerns about moving too quickly with hard recommendations. But again, Dr. Hannah, to your point, it does seem that, what has worked in some areas, in parts of it have worked very well, parts of it not as much. We've talked to Tennessee and to West Virginia and to Alabama and to Chris has talked to Indiana, and I do think hearing from others is very helpful. I also think that Mississippi is its own unique state with its own unique set of gifts and issues that we have to step through. So I do think we're going to have to probably fashion something that fits us. And so how quickly can we do that is the real question. I already have seen such good positive change, but there's some barriers that are still there that we have got to figure out how to step through. Bringing Medicaid to the table will be very, very helpful. So we'll get busy with inviting Medicaid and see if we can get some engagement here by our next meeting, October the 16th. I think that would be really helpful. I know it might be tough. We can do it. Okay.
This is Keith Duncannon, and I have a comment. I think that the state needs to keep a very strong thumb on if we wind up with 9 areas, that they need to have a strong controlling thumb so one contractor doesn't run through the money they've been allocated for the year, and then there's 6 months left in the treatment year, that there wouldn't be funds to treat. And I know this has happened in the past where my agencies had to come in and bring several providers on from a contract that they had run out of money. And they had some excellent therapists that were treating children, and the children were going to be left without services. So we had to move very quickly to bring them back in the field to keep those children being served. So I think that Chris Adcock, someone needs to have a strong thumb over each module or section of the state to make sure that the funds are being utilized appropriately and being paced to last the entire year to treat the number of children that needs to be served.
Yeah, I think Keith brings up an excellent point. I've heard echoes of that across the years as a fairly common complaint about folks who were not, quote, within that system. So absolutely, I would agree with Keith.
Dr. Edney.
My thumb is pretty strong, and we're talking about the flowing of federal and state dollars. And that responsibility will fall back to me if we fail audits, if we don't have program integrity, then it's my reputation on the line. As a lead agency, that's who our federal partners will hold accountable. So we have to hold our community partners accountable, just like we do in everything. I mean, we have contracts and subgrants, with community partners all over the place, but we have to hold them accountable. So whatever's happened in the past, I will learn more about, because this is the first I've heard that story, but I want to know exactly what happened so we know how to prevent that.
Thank you for that. I think Keith is absolutely right. In the past, we were told by parents that they weren't able to receive services because that area had run out of money. So yes, it'll be interesting to see what you can uncover as to why that happened and how. Any other questions, comments, concerns?
This might be something we've already covered, but quick question about the interplay between social work for high-risk families who may have difficulty getting access into services and the actual early intervention services. Just how that kind of plays off of each other. Like if a family is enrolled and they need that social services, is that kind of picked up throughout the process, or is that something we need to, as providers, need to dig into a little bit more for families who need that. So say there's like issues with transportation, getting to sites and that kind of thing. If there's like a standardized approach or way that we handle that.
So are you talking more about the at-risk child? Or yes.
Yes.
That's one area in which we have not served children, at least in the last several years, from what I know, that presumptive eligibility, like coming out of the NICU, or a child who is sort of on the borderline, the children living in deep poverty, what, almost 30% of our children live in poverty. That has not been a part of the services from what I understand. And Chris, I'll give you a minute to comment on that, but I will say that I think there's a desire for us to be able to serve more of those children if we can. And again, that might just mean, not just, but the work of perhaps a case coordinator or a case manager when the child doesn't need in-depth services, but perhaps more help accessing other services. But again, Chris, I don't know if you have any thoughts about that.
Yeah, I think it's definitely something that we need to look at because we know that we do, excuse me, have so many children who are defined as at risk in one way, shape, form, or another. And sometimes they need just connection to service. Sometimes they need transportation to service or even other things depending on the child and the family. But I think there's also an opportunity, as we've talked about, even with looking at a current pilot project, is how do we also enroll children in the program based on that clinical judgment. And some of those factors can be addressed through that clinical judgment. And I don't think just from looking at the recent history that we've really capitalized on that as a mechanism to enroll children in the program.
That's helpful. The only reason I say that, I've been using the Healthy Moms, Healthy Babies program a little bit more, and
yeah,
very grateful for it. And I was wondering if there's a way to meld the two, because for family, there was like a couple of families where they're in the early interventions program, and then we kind of utilize that program to get them social support to get to the site that they were going to. So just a way of like using already existing things and maybe melding them together would be one idea.
Yeah, sometimes it's helping people figure out how to utilize those natural supports and those natural resources that they have that maybe they just can't identify at that moment in time.
Yeah, I think it's important to remember that the funding that does exist, not from the federal government, is IDEA funds and not at-risk funds. I'm certainly a fan of prevention, but that may be a different kind of flow stream for sources for those kinds of families that don't come under the purview of IDEA. So there's been in the past some pushback that I recall for the definition of at-risk children, and the need to be very careful with that. At risk, often from an IDEA perspective, are children with disorders that we know will result in delays as they mature, but may not reveal themselves as true delays in the moment.
So thank you, Dr. Hennington. I'll just, not to interrupt you, but I do believe that other programs can serve at-risk children. And
yeah, and I know you made so you're not saying that programs can't serve at risk at all. So maybe we just need more understanding of where you're coming from. But I do have the federal statute, and it says at the state's discretion, the program can serve at-risk infants and toddlers. And to me, what I've seen in other states is that can be defined based on kind of what the state wants. And I'm sure you're very right. We would need to be very careful and check with OSEP and the federal regulations to make sure that we're compliant with that. But I have seen other states include things such as abuse or neglect, or I'm not positive about poverty, but those kind of comorbid situations.
Okay, any other questions or comments or thoughts? I agree 100%. We need to make sure whatever we recommend that it's within regulations, and we'll certainly delve into that. I can say we are very lucky, again, to have Pierre and their help in the research. So again, I know I thanked y'all 100 times, but I mean it. We are lucky. And thank you for everyone and your thoughts and comments. Okay, I think we were scheduled to be here until 3, but if there are any other thoughts, we have 9 minutes. I'm happy to entertain them. And if not, I would be happy to entertain a motion to adjourn. Thank you, Biz. A second?
A second. This is Denise.
Thank you, Denise. All right. I know everybody's in favor, so we will adjourn until the next meeting, October the 16th, and we hope to be close to having a draft going by then. Just a general, we already have, actually. Mary Claire has already made an outline, not anything in the body, but an outline. And so we will have that for us at the next time. And then when we have a draft ready, we will get it out to all of you for your comments and questions. So thank you again, and I will see you on October the 16th.